Thank you for joining CFI for our webinar, Maximizing Quality of Life in Nursing Homes, sponsored by CENI. I'm very pleased to present a friend of Greenhouse, Dr. Laird, who received her medical degree with honors from Georgetown University of Medicine in 1991. She completed an internal medicine residency of geriatric fellowship. Dr. Laird is a recognized expert in diagnosis and care of patients with Alzheimer's disease and served for 25 years as medical director for two state of Florida memory disorder clinics. Dr. Laird is now the founder and chief medical officer for Navigating Aging Needs. She is also a principal investigator at ClinCloud Research in Viera, Florida, focusing on clinical trials for Alzheimer's disease. She also continues as a community faculty member of the Florida State University Department of Geriatrics. Dr. Laird is a passionate advocate for the support of family caregivers and co-authored the book, Take Your Oxygen First, Preserving Your Health and Happiness while caring for a loved one with Alzheimer's disease. I am thrilled to have Dr. Laird join us for the third time to help us in a much needed topic for elders that are living in nursing homes, assisted living, and greenhouse homes. Thank you.
Oh, thanks, Carol. That is really a very kind introduction. And I love being here with the Greenhouse Project. And I always feel like I'm among my people when I'm here with all of you who have chosen to spend some time with this topic, because you guys know not a lot of us talk about this and get the opportunity to be able to talk to other people about it. And so I'm really happy to be able to focus ourselves for an hour on this really important topic. So Amber's going to advance slides for me. I also want to thank CENI for allowing me to be here too. Again, we're all in this because on the next slide, you're going to see our fact that's going to kind of surprise us all and get our minds thinking about how important this topic really is. So next slide, Amber. Yeah, that's right. So the key data point that I want everyone to focus on as we get started is the fact that almost half of our individuals who are long-term residents, even if they're low risk in a long-term care facility, that elderly population, almost half of them are at risk to at some point lose control of bowel and bladder. Now, if we think about the mission of the Greenhouse Project and all that that entails, and we realize, we all know personally what a blow to the dignity of an individual these symptoms can be. It just really, to me, sets the stage for us to step up to the plate and have some challenging conversations. Amber, let's go to the next slide. Because one of the things I want to do is kind of level set us so that our knowledge, we've all got the same understanding of what we're talking about with this incontinence. We often immediately think urinary, but today I'm going to broaden it out because incontinence can impact urinary tract, of course, but it can also involve the bowels and fecal incontinence or bowel incontinence. So we're going to talk about both of those. And I promise you by the end, we'll have strategies. So you'll have something to take home, take back to the office to be able to make a difference, hopefully tomorrow, in the care of people you're responsible for. And one of the really important level set issues about incontinence of bowel and bladder is that it's not, I repeat, not a normal part of aging. So we'll review in a minute what happens to the body as we age, and it does not include incontinence happening unless there are other factors at play. Aging does kind of create an environment where it can happen, but other factors have to be at play. And that's really why those of us interested in caring for this population need to be aware of both what aging does and what these other factors are. And the reason it's so important is listed here in front of all of us. Look at the impact of bowel and bladder incontinence. You see emotional problems highlighted in the first box, increased rates of anxiety, depression, a result perhaps of incontinence is self-isolation. So removing yourself from the social world around us. We've learned from COVID, haven't we, what social isolation does to all of our sort of functions and abilities to have a quality of life as a human being. Decreased quality of life then is one of the major concerns of someone who's experiencing one of these or both types of incontinence. Functional decline is another aspect of it. Once we stop using our bodies, we tend to lose function. And that can certainly happen in this case as well. As we lose function, we've got a higher rate of being injured from a fall. When we fall and we're older, we have a higher rate of having a fracture from the fall. So all of these, you can kind of see they're a cascading set of associated problems. And one of the reasons I sort of start with all the bad news, and I realize this is a very sort of dark introduction, but the reason is that what we're going to talk about from a strategy standpoint, there is a lot of potential to help people with these symptoms. I'm not going to pretend it's an easy fix and I've got a secret that's going to fix these problems. No, but between 50 and 80% of most people's frequency of incontinence can be reduced by some smart strategies. So even if we aren't making the problem completely go away, you're reducing the frequency and the severity of the problem, and you're probably going to reduce all of these associated effects as well. And that's the key to this whole topic, is understanding it's not normal. There's something happening creating these symptoms. These symptoms are going to have negative effects, so we need to pay attention to them, even though it's a bit uncomfortable. All right, next slide. Pop quiz. Now you're lucky we're not in person because I could easily pick on somebody, but I won't. But let's just do this as an intellectual exercise with each of us thinking through, which is the most common condition among older adults in long-term care. Now you're probably thinking, well, we know the answer because this is what her talks about. And you're right, it's urinary incontinence. Oh, Amber, yeah, thank you. It is urinary incontinence. If we could stay on that slide, Amber, that would be great. So it is urinary incontinence that's the most most common. But what I wanted to do was give you a couple numbers just to anchor your knowledge. So urinary incontinence, if you take a big group of long-term care, mostly older people, how frequent do you think that is? It turns out it's somewhere between 65 and 80% of most groups, large groups of older adults in long-term care, have either bowel or bladder incontinence. Now, you're thinking, wait a minute, doesn't hypertension happen pretty frequently? Because I bet many of you thought that's probably the answer. In the same large groups, hypertension is 50 to 70%. So it's close, it's definitely close, but it's not as common. And then interestingly, on the other two that do fortunately get some attention, surprisingly, depression comes in at about 30%, and diabetes is about 20%. So interestingly, some of the conditions we think of as the conditions that are more frequent and needing more attention are actually not among the symptoms that are the most common. And if you think about it from a day-to-day quality of life standpoint, if we were going to say which of these impacts that quality of life, we all know which of the answers would be the answer for that too. And so urinary incontinence is important. fecal incontinence would be right alongside, although there's a lot less data for that. So the statistic I gave you was specifically for urinary. So, all right. Amber, we can go ahead and move on, because what I want to do now is continue kind of, setting a foundation of what we know about how the body ages. And there are definitely changes as we age that make it more likely that you could have incontinence. And in the case of both the urinary tract and the bowels, we'll kind of toggle a little bit. Sometimes I'll talk specifically about the urinary tract, but a lot of this goes to both of these body parts, body systems at the same level. So for example, cognitive. Now, I'm not talking dementia here, but cognitively speaking, as we age, the signals that get sent to our body to know something. So our body is really what tells us, oh, you have an urge to go to the bathroom, or it's time to empty your bowels. That's a cognitive knowledge of the body. Those signals get less robust. So there's less ability to know in a timely fashion about the need to empty the bladder or control the bladder, and or empty the bowels or control the bowels. So that's a good example of aging kind of sets us up for problems, but as we said, there's going to be other things that we have to watch for that actually create the incontinence. So many of you know that from a female standpoint, the urethra has a lot of changes from a dryness and atrophy. The whole pelvic area is subject to that. The bladder itself has a decreased capacity. It's not as easily contracted or expanded. It's becomes less of a good sort of retention device. And the rectum can also have changes from an aging standpoint in which it becomes less effective too. Its tone is not as strong. The musculature around the rectum is not as strong. All of that is definitely something that as we age, so a 90-year-old will have more trouble than a 70 simply from aging alone. And then, of course, you're familiar with the male version of changes in the pelvis, and that's the prostate having its tendency for enlargement and potentially obstruction of the male urethra. Now, the good news, if there's any to be had on this slide, is about the kidneys. And interestingly, in this case, most of the time, the kidneys aren't necessarily involved in creating incontinence, believe it or not. But they do slow down to some extent, but mostly they're not really involved in the issue of control of bowel and bladder. So, all right, Amber, I think we're good to go to the next slide. I mentioned that I wanted to zero in a little bit on urinary, and we'll do the bowel too. So on urinary control, so keep in mind when you're thinking about incontinence, it's really an act of control, of controlling that urine because it's going to get made and got put into that storage container. So can you control when it comes out? And that's what it really sort of boils down to. So the bladder itself has some other effects. So now we're not talking aging. I mentioned what happens from aging, but now I want to talk about other aspects of health or other conditions that can create changes that can affect the bladder that we know has a little bit less of an ability to be a robust storage container. So things like obesity and more weight, literally weight on that organ. Constipation is a big one, so keep that one in mind. When you think, we have another slide in a minute on the profile, and you can remind yourself that the bowels are running alongside and behind and kind of around the bladder. So if the bowels are obstructed or constipated in any way, it can be pushing on the bladder and creating trouble. It's a very common sort of partner to bladder problems are bowel problems. Things like coughing, people who have chronic cough, the pressure on the bladder. Neurologically speaking, you can see the list of diseases on the slide. And really what those diseases all have in common is in that title, neurologic. It's creating a further degradation of that nervous system signaling that I was talking about. So the bladder is really a very sophisticated organ, and all of the sort of associated diseases that we're talking about here, unfortunately, can chip away at its very sophisticated neurologic ability to maintain that control or release at the right moment. So those are all individuals who, on top of aging, would have this potential reason to have a decrease in their control. Now, I mentioned as we move to the kidney section, I mentioned that the kidney itself really often continues to work reasonably well, and that's in aging, right? So I said aging-related kidneys end up working well. But what doesn't work well is if the kidney is subjected to a lot of dehydration, high blood pressure, or diabetes, it too has a decrease in its ability to function and maintain the fluid part of urinary control. So sometimes we don't get enough fluid into the bladder, and that can cause trouble. Sometimes we get too much, and that can cause trouble. So this is an example where kidneys age okay, but they can have other conditions that can relate to urinary control. And finally, the one I want to put in your mind and encourage you to try to not forget this one. Urinary control. I've sort of talked mostly now thinking about that bladder, like what's helping keep the bladder strong so it's controlled when it might release its urine, right? Well, this category, musculoskeletal conditions, keep in mind that that's the other part of control. And that's, you've got to be able to get to the bathroom to have the time right to release the bladder. So you might be able to control it for a long time, but if you can't get to the bathroom in time because of arthritis, either in your hips, knees, or even arthritis in the fingers, and you can't manipulate the zipper or the buttons of your pants to get to the commode quickly enough, that's an example where the bladder can only do so much, and we've got to have these associated abilities to functionally get ourselves in a position to be able to use our whatever control we have, use it as much as possible to have controlled urination or bowel movements. And unsteady gait is another example of that sort of thing that tends to have to do with the speed with which you can get safely to the bathroom. So individuals who don't have good gait and balance tend to have to move more slowly to maintain better balance. And that sometimes isn't, that's a challenge for a bladder that for other reasons is under stress. It may not be able to wait for you to get to the bathroom. It's kind of how that works. So I wanted to give you a sense, and this isn't the entire list of things that can impact, but this is probably some of the most common additional conditions and things to think about when we're talking about urinary control. All right, thanks, Amber. Let's go to the next slide, because I wanted to do a similar thing when we are thinking now about bowel control. So if you think about bowel continence, we have situations in this case where, kind of like the kidney producing the fluid that goes into the storage container, we've got the colon and our whole digestive system producing the component of stool or bowel movement that is then contained within the colon, and finally rectum, which is the storage part of bowel movements. And then we have the process of storing it in a controlled fashion and only releasing it when it's appropriate, so that we do have both issues related to the digestive process of creating the bowel movement and the storage process. So, and this is the kind of picture I was talking about where you can kind of get a little better sense of the relationship between the bladder and the colon. It still doesn't necessarily show it completely, but you can kind of picture if on the picture here, you can see the dark brown appropriately is the rectum. And so if that were full of stool, you can kind of, it's not quite drawn to scale, but with the bladder, two sort of organs ahead, that can be actually impinged upon and crowded out and made unable to release urine at the right time because of the constipation. So they kind of do potentially interact with each other. But back to the issue of this, when we're talking about bowel incontinence, we need to think through how the stool, the material is being created. Are there any changes with regards to that process and storage process? So the common conditions that can play on top of aging related changes and impact bowel incontinence are diseases like or disorders like irritable bowel disorders. So the kind of functional constipation or diarrhea syndromes that you might see diagnosed or hear talked about. People for whom the control and regularity of their bowel movements is not regular and not steady and reliable. Oftentimes with those sorts of symptoms, the use of laxatives is can be part of the solution, but it can also be part of the problem if they've been used over a long period of time, where the bowel becomes less responsive and able to do the usual work of stool formation. So that in our older adult population, that becomes an important part of their history to understand. If they have needed laxatives for a very long time, that may be part of the situation now. Because what that tends to do is create irregularity in how the colon and rectum expand and contract. And that expanding and contracting is part of what is involved in the control. So that tends to be problematic, especially for people who have chronic irritable bowel disorders and chronic laxative use. So something to think about. There are also kind of more clear-cut challenges that can create bowel incontinence. I guess the clear-cut was a good term, although I didn't mean to say it that way. But people after prostate surgery or people after bowel resection and people with even hemorrhoid repairs, there are situations where anything manipulating and changing the rectum and especially the anal sphincter area, including childbirth, by the way. So I don't have it on there, but any of you taking care of older women, keep in mind the episiotomy from 70 years ago. If it disrupted the anatomy in that area, there's a potential that you can have less control than you would have had otherwise. And so that's something to ask about and to know if an individual has that problem. Nerve damage goes along with that, and nerve damage in the bowel tends to come from osteoarthritic problems of the lumbar and sacral spine. That's probably the most common, as well as in the pelvis. So any of these surgeries relating to the prostate, as we were just talking about from the standpoint of hemorrhoids and anal surgery, that sort of thing. I guess I do have childbirth down there, but I wanted to specifically point out that it could be childbirth vaginally, but it can also be the episiotomies, any sort of repair that had to be done for a tear that can sometimes involve the rectum as well. And I'm not going to skip over the part that says weakened pelvic floor muscles, because in both cases of bladder and bowel incontinence, it's a huge risk factor for any of our patients that are just frail in general. So if you look at someone and you're like, this is a really frail person, the likelihood that they have incontinence is quite high simply because frailty, which is, in this case, I'm using it to refer to someone whose muscle mass is reduced and who doesn't have strength in general. Well, we forget about the pelvic floor muscles, and those are really, really important. So you see in this picture here, the bottom of the picture is the pelvic floor. And if that is not as strong as it used to be, and it sags, that whole setup, the whole anatomy is impacted, and the control of the sphincters that are set up to work properly is predicated on this normal anatomy. So when we have this abnormal anatomy from the weakened musculature, it's a setup for incontinence, either bowel or bladder. So we sometimes forget that our weak patients, we think more of getting up out of chairs, walking, that sort of thing. We forget that it can be a systemic problem, especially for the more frail that you get. So, okay, so let's go ahead and move on. I want to point out a few things that are kind of, I call them other factors that can impact urinary control, because I think these are some of the things that we have a little more control over too. So with urinary control, it's interesting. A lot of women, especially, but men too, but I hear it mostly from the ladies. Once they start having urinary problems, they'll stop drinking because they've, of course, figured out that the less you drink, the less you leak. So we have to kind of educate them that that's really not the issue. It's more of usually it's more of a timing issue, and we can help them understand. But dehydration is not the answer to improving your urinary control for a variety of reasons. Bladder irritants, carbonation and caffeine are probably the two biggest to keep in mind. We often remember caffeine, we often forget carbonation. So keep that one in mind. Toileting habits are a challenge, but the one that can sometimes be problematic is too frequent voids. I'm a big believer in every 2 hours, but more than that can sometimes be problematic. So that's a tricky area, and every person's body, we got to keep up our principles of person-centered care. So I do have plenty of patients for whom the 1 hour voids is just what they need. But in general, you're going to kind of start with 2 hours being kind of what you want, and not a lot more than that. And then we already mentioned gait speed and hand dexterity, really important, or you should be switching their wardrobe to make it more useful for them. Okay, next slide. Yeah, on the bowel control, I think the other thing I wanted to mention is this is an area where I don't usually do much by age. I usually say, well, who's the person, not necessarily just the age, but the evidence about pelvic floor weakness actually is pretty strong that age alone is a risk factor for that. And with bowel incontinence, that's a big risk factor. So the older your patients, the more you just have to pay attention to this. And then, anyone who is accustomed to having diarrhea, it is very common that they will move into a full kind of incontinence cycle. So it's very important to find out if someone has had that irregular bowel habits from the past. If diarrhea was a big part of it, it's very important to kind of start working with them and have someone help with regards to trying to find some ways to control. Fecal urgency is also a very common signal. Now, I said that a lot of times you don't get a signal, but the patients that do, that's a really important symptom and signal to listen to, because often they can't respond to it like they need to, and that creates other problems. So if you do have someone who's having an urgent feeling, that's a really important symptom to pay attention to. In addition to getting them to the bathroom, sometimes we just do the getting them to the bathroom and we don't follow up on the fact that they're having such a feeling. And in some cases, they're having that feeling because there's an impending problem. So you really want to make sure that person gets medically evaluated. And then urinary incontinence. So many times people who have urinary incontinence are going to later have bowel incontinence. So you really want to start paying attention to both. And then diabetes, if we have to take and look for a crossover amongst the risk factors, it's your patients with diabetes. They're going to be at risk for both of these, primarily because of that neurologic connection and trouble that diabetes creates. So that would be one of the ones to just keep in mind that often has crossover and both symptoms can be going on. So, all right. I think we've given, I know that was rapid fire, but I'm hoping you've got some thoughts going through your mind about different things that affect us as far as our urinary and bowel control because of aging, and then some of the medical conditions that are common in these age groups and commonly associated with it. I promised you we'd get to some strategies, so here we are. On the next slide, we're going to start with the most important strategy, and that is, you really want to start by thinking through the symptoms. You've got to really be able to understand who's likely to have a problem. So you need to know who's at risk. I think this material that we've just covered can give you a sense as you look at the people you're responsible for. If they're at risk, you can start there. And then you do want to ask, you need to find out some information. There can be a lot done with this by power of observation by seasoned clinicians. But in general, you're going to want to, if the situation's appropriate, talk to your patients about it. I'll comment in a minute about some ways to talk about it because it is a sensitive area. One of the key things that you want to figure out is you're just meeting this person, but is this symptom a new symptom, or is this an acute problem, or is it a chronic problem? Kind of stumbled over that, but what I meant by that is it something new and it's just happening for the first time, or have they been battling this a long time? It's going to kind of move in different directions based on that, but you really want to figure that out first. I think we often assume a couple things. If it's happening at all, we just assume, well, they're whatever age, that's what should be happening. But if you ask the question, and let's say it's an acute problem, and they say, well, it just started happening 2 months ago. Well, they've been 86 for a long, they've been in their 80s. If they're 86, they've been in their 80s a long time and it wasn't happening. Why at 86 and 2 months did it happen, right? Start thinking, realizing that that's not necessarily normal just because they're aged. And then even with chronic, let's say you find out it's been happening for 10 years. That doesn't mean you stop. It just means you now have a chronic 10-year problem that you're thinking about. But you're still going to keep thinking about it, because whether it's acute or chronic, that statistic I gave about being able to reduce the impact and often the frequency of incontinence, that stands. So I'm saying ask the question, find out what it is, but intend to continue to find out how you can help the person. I put the bullet about get data from a resident or family. And I guess I meant from the resident, or like I said, your observation, or someone who knows the individual. You really want to be able to understand this long-term acute or chronic information. And sometimes, of course, we have to go to others to be able to do person-centered care if our resident is not able to participate that way. There's hopefully an advocate that knows them well and can provide you that information. And then I've got talk to the team. Very often, of course, we're in a team setting in long-term care, which is great. And if we're all paying attention, it can be a tremendous team activity and effort and outcome to be able to help some of these individuals. And the reason it takes a team, we'll touch on in just a little bit, but if you think about it, bowel and bladder continence is a 24/7 thing. So you can't just ask the day shift. You can't just ask the night shift. It's really something that you all have to be invested in and working on. Because even your solutions, you do something at night, it might affect the daytime. If you do something in the day, it might affect the nighttime. So there needs to be a kind of a team effort around these issues often. So, all right. I mentioned I'd give a couple tips about, talking about this because a lot of patients don't want to talk about this, but go ahead and ask. You'd be surprised how many people are okay with talking about it. And we're kind of just waiting for someone to talk about it. Just like we have maybe a tendency to think, well, they're older. That's kind of what happens as you get older. Some of our patients think that too. And, why wouldn't they? Because maybe no one's asking them and telling them it's not normal. So everyone's in this, sort of state of not being aware that there's something we might be able to do about this symptom. So you as the healthcare professional, you got to step up and ask. Now, I have found that the term incontinence, we all get it, but it's not like the best term. And there are people who get it plenty. But in general, the trouble controlling phrase seems to work and leaking seems to work, at least in my experience. I'll be interested to learn from the rest of you if there's other terms that really work. But that's sort of what I've gravitated to. Any trouble controlling your bladder, most people get that. Do you leak when you cough or sneeze? Do you leak as you're going to the bathroom? And asking about bowel movements, I tend to use the term stool, and that tends to work, or bowel movement. But that's sort of what I've come across, and I just saw something coming in for the chat. I can't look at it completely, but thank you for contributing because someone just said dribble. Yeah, that's a good one, similar to leak, I think. So in any event, it's good. Sounds like some of you are accustomed to asking and talking about this. Please do it. Please train younger people to know that they really need to do it too, but do it in a respectful way. Do it one-on-one, do it quietly, just do it with the kind of care and compassion. This is a good one for put yourself in their situation. How would you want to be asked about this? But please ask. All right, Amber, the next slide. Yeah, so once you ask, and this is sometimes I think why it doesn't get asked is because it can be a little bit of a complicated, situation to even figure out, what kind of incontinence it is and why it's happening and how you can fix it. So it's not insolvable, but it does have some complexity to it. So a diary, or just a general term for something that helps you understand the reality of what's happening for someone. So this diary or log is a way of helping communicate, again, especially among the whole team, what's happening for an individual with their bowel and bladder control. And this is just one example. There are a lot of examples available online. And the main issue is you want to observe for several days. In general, I tell people 3 to 5 days, you're going to generally get a good sample of someone's routines. And you really want to get the key information about when they're using the toilet, when they're having, leaking. And this would be for both bowel and bladder. You could start with one or the other to be, more clear. Everyone does it a little differently, but you generally want to know the timing, when there are accidents. You also need to know what's being taken in so that you understand what's coming out and what's going in. So you're doing that. And then a really important aspect is keeping track of the undergarments that someone's using and making sure you understand, if the undergarment was sufficient, or was it by the time it got changed sort of dripping, or was it not dry, not wet at all for a prolonged period of time. And we have to think about the dehydration. So all that kind of thing, if you're documenting what you're using and what kind of state the product was in, you'll end up with all this information. And read through this slide because it really sort of gives you a lot of good questions to ask and things to monitor for just a few days. And then you're going to be able to look at it and have a much better perspective. If you have a medical team coming in, this can be a good time to enlist your nurses, your other nurse practitioners, physicians, whoever you have access to, bring them into the picture. The data will help everybody, and you'll get a much more, you'll get a much better approach to starting to think about some strategies for your resident. All right, and let's go ahead. We're not going to have diaries, but I have created cases in which I'm going to give you kind of some information like you would get from a diary. So this is good too. As you listen to the cases, you can kind of see the types of things that you need to observe for while you're thinking about helping someone. Okay, so we'll go to the first case. Oh, but before we do, see, I'm glad we put this in here. As we do the cases, this is my favorite part because it really zeroes in on that person-centered care. So, you know, all my years of doing this, every time I'm with a patient, it's just like such a rush to know that you're with that person. And then you start hearing their challenges and you've got some solutions for their challenges. I mean, that's quite a privileged position we're in. And this concept of doing it with that mind of focus that we want to do it for, but also with them and find out what's important to them. You know, they're part of this solution, or they have an advocate for them who's part of the solution. And I think letting the advocates know that you're interested and focused on this is very important. I will tell you some of the most common complaints I get. So when I'm in my medical clinic seeing patients, a common complaint I get from family caregivers is around their loved ones' care or lack of care in their eyes for incontinence problems. Because that same sort of embarrassment and loss of dignity that we feel, the caregivers feel for their loved ones. So this is a really, you know, rich area where we as clinicians in this type of care setting can really make a huge difference, both for our patients, so the person-centered care, but also for their loved ones, those care advocates. So I think that's really important. So here we go. So we're going to meet a few people and do some person-centered care for them around their incontinence. Okay, Amber, now we're ready. Okay, so here's our first gal, Mrs. S. 84, widowed, no children. You guys are it. So you're her team, you're her care advocates. Her main issue has been musculoskeletal, osteoporosis, osteoarthritis everywhere. She's been in long-term care 5 years already. Cognitively, she's good. She's a little slow and needs a walker, needs ADL setup only, but you know, she's doing okay. Now, urinary incontinence, 3 years. She's starting to seem a little more down and withdrawn. So right there, that's a good example of, I want people to start thinking about moods and behaviors down and withdrawn. How often do we think urinary incontinence? I don't know, but maybe after this case we will. Next slide. All right, so here's a lot more data. This is kind of what you would get if you were doing a bladder diary and if you were taking a few minutes to think about, well, are there age-related things or other problems that this Mrs. S has that can create, that can be contributing to her symptoms. So I'm going to just point out a few for time's sake, but some of the big things that jump out in this particular case, and you can look at it again when you have more time, but her frequency is the biggest thing that she mentions, 10 times a day, 4 times at night. So we've already said she's got trouble with mobility, but she needs to go 10 times during the day and 4 times at night. So there's both leakage when she's trying to get there, that's the leakage with urgency. Also, when the leaking with cough and getting out of a chair, I didn't mention that earlier, but that's a really common stress-related incontinence, is the actual, because of the pelvic floor being weak, actually just getting up out of a chair can trigger bladder leaking, and that's really common. So you can kind of picture, this is a person who's having, almost no control, right? She's 10 times a day in the daytime, 4 times at night, struggling to get there. You can see in her Medicaid, and so she's using a lot of pads and things too, 4 to 5 at night, 1 to 2, 4 to 5 in the day, 1 to 2 at night. Her medications, you can see kind of a common list, including twice a day of a water pill. So that, hopefully, I haven't mentioned medications yet, probably deserves to be mentioned, of course, and this is a good example, is why I put it in here. Her medical history, as you can see, has the common things, diabetes, hypertension, but again, is very focused. Those last 2 bullets really focuses in on how much her mobility is a factor. And then the other information, and this is important, she has soft bowel movements every 1 to 2 days. I really want to challenge you to, when you have someone who's incontinent, please find out about their bowels, because you're not going to be able to fix one or the other if you don't know about them. And they often go hand in hand. So find out. Good news here, she doesn't have constipation. She's good there. She does drink 6 cups of water, which is great because she's got all that Lasix going. 2 cups of tea and 1 cup of coffee every day. So we may have some clues now, alongside of hearing about the frequency, knowing about her medication, which is twice a day, if I didn't say that earlier. And now we also know she has a fairly high fluid and caffeine intake. Okay, next slide. So your minds are probably already going as far as what you want to do for her, which is great. But I just want to sort of zero in for just a minor second on the way I think about the types of urinary incontinence. And I want to suggest you think about that too. And what you can see is on the far right are the common words that you're used to. Functional urinary incontinence. So like people who can't get to the bathroom enough, people who are cognitively impaired and don't sort of know how to get to the bathroom. Overactive bladder and stress incontinence and overflow incontinence. Those are the other sort of big categories that we always think of. You can see I've sort of made the slide, moved it out and bracketed all of those under mixed. Any of you in long-term care, you're mostly going to look for the mixed incontinence, because most of your patients are going to have more than one. So I really encourage you to always start by expecting it to be mixed. You won't miss as much. So expect it to be mixed and work your way in. Maybe it's just the caffeine. I mean, maybe that's it. If she takes her caffeine away, decaffeinates her drinks, she'll be fine. Maybe. I don't think so. So that's why I would suggest thinking mixed and moving to more specific if that's the case. Okay, now we can get to some solutions. And I think I got to hurry up here. Okay, so for patient number 1, the first thing that's interesting for her is the functional side of things. So one of the things we haven't touched on much, but I think we need to, is what is her depression from? So if it's related to this problem with all this frequency and leaking, it's really important for her overall quality of life that we think about, we bring it up to her, we talk to her, we get someone who has a rapport with her to engage on her in that. And why is she not as active as we've seen her be before? Is it potentially because her access to bathrooms or her ability to use the bathroom is limited? Does she need different pads for when she's going to be at home and more absorbent underwear when she's leaving the house? Does she, again, need some different clothing? Those are things to think about from a functional standpoint. From an overactive bladder standpoint, timing of drinking. I love that she has 6 glasses of water a day, but she also has 2 doses of Lasix a day. So what's the timing of all of that? Talking to her about when she's taking the medicine when she's drinking and when she's wanting to be out of the house, away from the bathroom, you can actually kind of figure that out. And potentially have pads that she wears when she's going to be home and able to be there for the smaller leaks, but different, more absorbent pads for when she may be suspecting a potential for surges that are larger volume losses. And finally, I like this this set of strategies because it remembers, as I said, always think mixed. One of her problems was when she stood up or coughed, she lost urine. Kegel exercises are very underutilized and can work even in the latest age range that's been tested. So Kegel exercises can work. Often physical therapists will be helpful. Sometimes there's actually pelvic rehabilitation specialists that you can get, but physical therapists would be the most common, or someone in your GYN group. But those are really important. And even for someone with this much arthritis and frailty, I would definitely recommend adding Kegels. So, all right. Well, given the time, I think I'm going to leave the occupational therapist. Sure. Absolutely. It is important to know who in your area has the expertise, right? And it can come from any of those areas. Absolutely. And I also want to point out, Kegel exercises are important for both bowel and, pelvic floor therapists, bowel and, for bladder, we think of it, but bowel incontinence patients, it is also important for them and can be very helpful. So I think there are some more cases that you guys can go through and have the answers are there. But I think what I'll do is, given the time, I'll go ahead and stop because I think Carol was going to take at least some questions so we can do some QA and then we'll go from there.
Yes, so there's a couple questions. Two, I'd say they kind of go together. So, well, do certain diagnoses contribute to incontinence? So one person asked if lumbar spinal stenosis can contribute to incontinence, and another person asked about a C-section. So what do you think about those two?
So the first one I know for sure, lumbar spinal stenosis can definitely contribute. Now there's two ways it can contribute. A typical way for lumbar spinal stenosis to occur is a slow and chronic process of change of the lumbar spines as someone gets older and as arthritic changes set in. And what happens as our bones become more arthritic is we get less padding and more kind of bony processes, and that can all become kind of fused together in this stenotic way of making the area for the spinal cord less, making it smaller and starting to impinge the nerves. That tends to happen in a kind of a very slow, progressive manner. And yes, it can be part of what contributes to the bladder. The other type of problem for that for lumbar spinal stenosis is you can have acute problems. You can have someone who didn't have incontinence who has some acute problem in the lumbar or sacral spine that impinges on the bladder or impinges on the spinal cord as well. So that gets into where knowing if it's chronic or acute becomes really important, because in the first case of someone who it's just slow, steady, you don't typically have major nerve damage and have to do anything surgical or neurologically speaking. In the second example, if it comes on more quickly, that sometimes requires neurosurgery to avoid further damage to the nerves that are being impinged. So that's a good example of paying attention to acute versus chronic. And then the C-section, I do not know. I don't know that answer. So I'll have to look that one up.
You gonna Can you please clarify why too many voids are problematic? Does the bladder shrink?
Oh, good question. Thank you. No, okay. Yes, the bladder shrinks, but by this I mean, I mentioned that it gets less, its tensile strength reduces. So instead of being a nice kind of squeezable organ, it gets stiffer. So it shrinks in that it gets a little smaller and it doesn't like expand as much as it used to. So it can't stretch as much. So that's the shrinking part. Now, the two, so the answer is that's why, so yes, it shrinks. That the issue about too frequent voiding is this. I mentioned that the signaling to the brain is less robust as we get older. You can override the signal to some extent, but if you try to go to the bathroom too frequently, the bladder starts to follow that signal and gets used to that signal coming. But that's a different signal. That's you manually, so to speak, signaling the bladder. And that happens in addition to the regular signals coming from the bladder. And so there's a bit of a sort of confusion, if you will, about the signaling that the bladder's getting. And so it'll get less, you'll end up with less control. It's kind of counterintuitive, but you end up with less control if you go too frequently because the bladder doesn't know who to believe. If that's, I mean, it's kind of the way I answer that. So if you try to work with the body's normal rhythms, you tend to have better results. About every couple hours, the bladder for most people is full enough that it should want to release. That's the concept behind Q2 hour voiding, as opposed to going and kind of manually forcing yourself to urinate.
Right. I think we have time for one more question. And this is a person who has a client with stage 6 Alzheimer's disease that's immobile, isn't able to stand on their own, requires 2 people to help them transfer, is completely incontinent, and they want to help keep this person as dry as possible. They live in memory care, they don't call for assistance, and is sometimes resistive to having the people help them. She's asking about what can be done, and then wondered about a system, the PureWick system, or other ideas.
Okay. So I don't have as much experience with PureWick, so I'm not going to be able to say too much about that. But in general, that what you've described is a very, very, common situation. So I thank you for bringing it up. The most important thing about incontinence care, as you think about what to do for someone who no longer can control their bladder and bowel themselves, is keeping their skin dry. So a lot of people think of urinary incontinence and bowel management care as catching the urine or getting the bowel movement and getting rid of it. I think of it as keeping the skin dry. That's like that's the most important thing you do when you take care of someone like this, because many of the problems that we can get into are related to the moisture that's left behind. So for the individual who needs it, getting products that are able to be highly absorptive yet breathable, so that there is a dryness at the skin and an ability for the skin to stay dry. Breathability allows some airflow, if you will, so that there's no moisture at that skin product juncture. That's really important. And you can find some now, and I would direct this individual to talk to Deanna from Seni, because what's important about that breathability is that it keeps skin drier, but there's also ways to have products that you can use during the overnight to show you when a product is at its moisture level needing to be changed. So you also have the ability to tailor the changes to when the individual skin, which is your goal, is at risk. So that's one thing I would definitely think about. And as you're thinking about the types of undergarments too, it's important to realize it sounds like this individual now is supine. And so the type of undergarments that you may use for someone who's supine are different than someone who's up and about. And you want to think through that to make sure you've got the right type of undergarment and the right size for that individual, so that hopefully you can, keep the skin as dry as possible, despite, that being the way that this individual is going to be voiding and defecating for the rest of their life. Now, the issue of them being, upset about that is a whole different topic. But one of the things I believe is the case is the less uncomfortable someone feels with moisture and irritability in that area, probably slightly less agitated, perhaps. So again, that's a reason to use something that really gives you good, a product that's really going to leave someone feeling dry. Again, is a big part of it, I think.
Yeah, thank you for that. I would agree. So Deanna and her team at Seni have been really helpful with some of the organizations that I partner with to get the right products and creams for individuals to help them be to maintain their incontinence management as much as possible. And I know Deanna's on the webinar, so Deanna, if you could put in your contact information in the chat box, that would be wonderful. And I can't believe how quickly this hour has gone by. Thank you, Dr. Laird, so much, and Seni for being a sponsor. And then I just wanted to let everybody know that Greenhouse and Pioneer Network conference is coming up in November 11th to the 13th. It's going to be in Grand Rapids, Michigan. And if you come to our website, I believe the registration is going to be opening up next week. So it's really exciting, where we get to all be together in a room rather than on Zoom and really connect with one another. There's also for organizations that are interested in knowing more about greenhouse homes and developing them, how they work. There is a workshop in Ohio on a campus with some greenhouse homes on August 21st and 22nd. So you can go to the website, or perhaps Janet can put the link in the chat for the registration to learn more about that, and go to the and perhaps attend that greenhouse development workshop. And finally, Greenhouse has the Elevate Elder Care podcast. We get a new podcast every week. And this latest one is learning from the household models around the world. So lots of new information to tap into. Again, Dr. Laird, thank you so much for your vast knowledge. I so appreciate it. I
Oh,
hope
you're
everyone
welcome,
has a
Carol.
great day. Bye-bye.